Diabetes management. First one is nutritional management. The most important objective in the dietary and nutritional management of diabetes is control of total caloric intake to attain or maintain a reasonable body weight and control of blood glucose levels. Success of this alone is often associated with reversal of hyperglycemia in type 2 diabetes. There are 5 goals. One is providing all the essential food constituents, example vitamins, minerals, necessary for optimal nutrition. Second, meeting energy needs. Third, achieving and maintaining a reasonable weight. Fourth, preventing daily fluctuations in blood glucose levels with blood glucose levels as close to normal as is safe and practical to prevent or reduce the risk for complications. Fifth, decreasing serum lipid levels if elevated to reduce the risk for macrovascular disease. For obese patients, especially those with type 2 diabetes, weight loss is the key to treatment. Some obese patients who have type 2 diabetes and who require insulin or oral agents to control blood glucose levels may be able to reduce or eliminate the need for medication through weight loss. A weight loss as small as 10% of total weight may significantly improve blood glucose levels. For obese diabetic patients who do not take insulin, consistent meal content or timing is not as crucial. Rather, decreasing the overall caloric intake assumes more importance. However, meals should not be skipped. Pacing food intake throughout the day places more manageable demands on the pancreas. Meal planning and related teaching. For all patients with diabetes, the meal plan must consider the patient's food preferences, lifestyle, usual eating times, and ethnic and cultural background. The first step in preparing a meal plan is a thorough review of patient's diet history to identify his or her eating habits and lifestyle. Caloric requirements. The priority for a young patient with type 1 diabetes, for example, should be a diet with enough calories to maintain normal growth and development. Some patients may be underweight at the onset of type 1 diabetes because of rapid weight loss from severe hyperglycemia. The goal with these patients initially may be to provide a higher calorie diet to regain lost weight. Caloric distribution. A diabetic meal plan also focuses on the percentage of calories to come from carbohydrates, protein, and fats. In general, carbohydrate foods have a greatest effect on blood glucose levels because they are more quickly digested than other foods and are converted into glucose rapidly. Carbohydrates. Carbohydrates consist of sugars and starches. Little scientific evidence support the belief that sugars such as sucrose promote a greater blood glucose level compared to starches. Example, rice, pasta, and bread. All carbohydrates to some extent affect the blood glucose to different degrees regardless of equivalent serving size. Next one, fats. Total intake of dietary cholesterol to less than 300 mg per day. This approach may help to reduce risk factors such as elevated serum cholesterol levels, which are associated with the development of coronary artery disease, the leading cause of death and disability among people with diabetes. The meal plan might include the use of some non-animal sources of protein, example legumes and whole grains, to help reduce saturated fat and cholesterol intake. In addition, the amount of protein intake may be reduced in patients with early signs of renal disease. Third one, fiber. Increasing fiber in the diet may also improve blood glucose levels and decrease the need for exogenous insulin. There are two types of dietary fibers, soluble and insoluble. Soluble fiber in foods such as legumes, oats, and some fruits plays more of a role in lowering blood glucose and lipid levels than does insoluble fibers. Insoluble fiber is found in whole grain breads and cereals and in some vegetables. This type of fiber plays more of a role in increasing stool bulk and preventing constipation. Both insoluble and soluble fibers increase satiety, which is helpful for weight loss. If fiber is added to or increased in the meal plan, it should be done gradually and in consultation with the dietitian. Fiber-rich food choices within the vegetable, fruit, and starch bread exchanges are highlighted in the list. Food classification systems. Exchange lists. There are 6 main exchange lists: bread, starch, vegetable, milk, meat, fruit, and fat. Foods included on one list in the amounts specified. The food guide pyramid. The food pyramid consists of 6 food groups: bread, cereal. First one is bread, cereal, rice, and pasta. Second one fruits. Third one vegetables. Fourth meat, poultry, fish, dry beans, eggs, and nuts. Fifth one milk, yogurt, and cheese. The sixth fats, oils, and sweets. The following guidelines can be helpful when making dietary recommendations. Number 1, combining starchy foods with protein and fat containing foods tends to slow their absorption and lower the glycemic response. Number 2, in general, eating foods that are raw and whole results in a lower glycemic response than eating chopped, pureed, or cooked foods. Third, eating whole fruit instead of drinking juice decreases the glycemic response because fiber in the fruit slows absorption. Number 4, adding foods with sugars to the diet may produce a lower glycemic response if these foods are eaten with foods that are more slowly absorbed. Other dietary concerns are: first one is alcohol consumption. The main danger of alcohol consumption by a diabetic patient is hypoglycemia, especially for patients who take insulin. Alcohol may decrease the normal physiologic reactions in the body that produce glucogenesis. This is thus if the patient takes alcohol on an empty stomach, there is an increased likelihood of hypoglycemia will develop. In addition, excessive alcohol intake may impair the patient's ability to recognize and treat hypoglycemia and to follow a prescribed meal plan to prevent hypoglycemia. To reduce the risk of hypoglycemia, the patient should be cautioned to eat while drinking alcohol. Second one, sweeteners. The sweeteners. Using sweeteners is acceptable for patients with diabetes, especially if it assists in overall dietary adherence. There are 2 main types of sweeteners: nutritive and non-nutritive. The nutritive sweeteners contains calories and the non-nutritive sweeteners have few or no calories in the amounts normally used. Nutritive sweeteners include fructose, fruit sugar, sorbitol, and xylitol, XYLITOL, xylitol. They are not caloric free. They provide calories in amounts similar to those in sucrose, that is table sugar. They cause less elevation in blood sugar levels than sucrose and are often used in sugar-free foods. Sweeteners containing sorbitol may have a laxative effect. Non-nutritive sweeteners have minimal or no calories. They are used in food products and are also available for table use. They produce minimal or no elevation in blood glucose levels and have been approved by a Food and Drug Administration as safe for people with diabetes. Saccharin contains no calories. Misleading food labels are: Foods labeled sugarless or sugar-free may still provide calories equal to those with the equivalent sugar-containing products if they are made with nutritive sweeteners. Thus, for weight loss, these products may not always be helpful. In addition, patients must not consider them free foods to be eaten in unlimited quantity because they may elevate blood glucose levels. Foods labeled dietetic are not necessarily reduced calorie foods. They may be lower in sodium or have other special dietary uses. Patients are advised that foods labeled dietetic may still contain significant amounts of sugar or fat. Patients must also be taught to read the labels of health foods, especially snacks, because they often contain carbohydrates such as honey, brown sugar, and corn syrup. In addition, these supposedly healthy snacks frequently contain saturated vegetable fats, example coconut or palm oil. Hydrogenated vegetable fats or animal fats, which may be contraindicated in patients with elevated blood lipid levels. Thank you.